quite remarkable. I was reflecting on the fact that when I first started in the field, none of these agents existed. We knew very little about these pathways, and there were limited options for our patients. And at this juncture, for almost every patient that presents with a non-Hodgkin's lymphoma or chronic lymphocytic leukemia, we have an approach that could hopefully induce a remission, prolong life, control the disease, if not cure the disease. That is astounding. And the spectrum of treatment options has expanded to the point where now we're trying to understand how to best combine these agents to minimize side effects and maximize efficacy. And we learn more in the period of a few months in terms of potential mechanistic approaches than we used to learn in years, if not decades. And so now the challenge with all of these great options is how to most effectively combine them and how to add on all the new considerations that are coming along. And that's going to require concerted effort on the part of all the investigators to decide on what the most appropriate studies are and how to structure them and then how to sequence them. Well, the standouts at this meeting and what we've already known about are the inhibitors of signal transduction, such as the B-cell receptor pathway inhibitors, as an example, the antibodies targeting specific molecules, some linked to toxins like brentuximab vedotin, which recognizes CD30. The proteasome inhibitors and how to combine them with other agents, the immune modulators, and that's all the thalidomide derivatives. We have a great deal of hope for the checkpoint inhibitors, the molecules like CTL4 inhibitors or the BD inhibitors. I should say, I'm sorry, PT inhibitors. So we know in the refractory setting a number of these agents work, and the question is how to most appropriately move them to the frontline setting. And you would take each disease because what may be most effective is slightly different. So in chronic lymphocytic leukemia, you have a number of agents now, from the Bruton tyrosine kinase inhibitors, the PI3 kinase inhibitors, the BCL2 inhibitor that show remarkable efficacy, and we have to figure out how to incorporate them and combine them. For diseases like mantle cell lymphoma, you have, again, the Bruton tyrosine kinase inhibitor. You have the IMiDs like lenalidomide that's effective. You have mTOR inhibitors, and you have a slew of new anti-CD20 antibodies that appear to be more effective than rituximab that we have to figure out how to combine. When you talk about the other indolent lymphomas like follicular marginal zone lymphoma, again, we see activity, and the question is what's the best way to bring these agents together. I think that'll evolve based on the prognostic factors that are associated with the disease presentation. And at the present time, we don't have compelling data to suggest that earlier intervention with some of the indolent lymphomas is an advantage. But that may change when we know the high-risk populations, as an example in CLL 17P deleted patients, whether an earlier intervention. We were one of the first groups to try and stay away from chemotherapy in a number of these diseases. So we recently reported on our treatment up front of chronic lymphocytic leukemia using a combination of alemtuzumab and Rituxan with results equal to fludarabine, Cytoxan, and Rituxan. And now we have a trial combining alemtuzumab and ofatumumab where we're getting a significant number of complete remissions in a 9-week window without any chemotherapy exposure. I personally believe that for the majority of the indolent hematologic malignancies, we will be using biologic therapies and not chemotherapy. also from my own background in treating cutaneous T-cell lymphomas, where now for more than a decade we've really eliminated chemotherapy as part of the initial treatment strategy. I see this as a future approach for the majority of these diseases. What I say to patients that I see now is that they're fortunate that new therapies have evolved that are less toxic, more effective, and that it's my anticipation we'll either be able to cure the disease or control the disease, and that the therapies that exist today will be able to allow us to sustain remissions, but if we can't control the disease, there will be new therapies coming along that will be equally, if not more effective. Well, the only way for us to advance knowledge is to do clinical trials. And as part of that activity, we're always using standard against what we think may be an improvement, but we don't know in advance. If we knew in advance, it wouldn't be ethical to do the trial. And so it's critical for patients to participate for their own benefit and for the benefit of humanity. We are entering a period of personalized or precision medicine where historically we would treat a large number of patients with the anticipation a small percentage may benefit. Now, because we know the targets, we actually anticipate the great majority, if in the future not everyone, will benefit.